My topic today is CRPS, chronic regional pain syndrome, case presentation. Some of you visited New York last year for WIP meeting, and probably remember New York as the Times Square, Central Park, Broadway shows. I want to show you my New York. This is 1 week expressway. Some they call it one bike. And there's a big railroad station over there. It's called Jamaica. Today I'm not going to talk about epidemiology and manifestation. I'm not going to mention pathogenesis and pathophysiology. Nothing about clinical trials, and definitely I'm not going to talk about evidence-based medicine. Instead, I'm going to talk about Fallon. Fallon is my patient, and she gave me her permission to talk about her. This is how she described herself. Once an A student who loved school, was involved in many extracurricular activities, was a competitive figure skater and violinist, I have spent the last couple of years incapacitated, paralyzed, and unable to sit, walk, or even eat. Her problem started somewhere in 2001. She had surgery in her left foot, and soon she developed swelling, color changes, discolorations, lower temperature, and so on. Her pain spread first to other extremities, then to the whole body, then to our autonomic organs. She was seen by multiple doctors. She had multiple procedures. She was consulted in most prestigious US hospitals. Somehow she ended up with me. She is quite literate. This is how she described herself. I'm sorry. This is how she described her pain. This disease is excruciatingly painful all throughout my body, 24/7. It is like being electrocuted or stabbed, as well as having flaming hot gasoline being poured on me. The slightest touch, even the caress of a loved one, the kiss from a parent, the touch of the sheep on the foot, the tightness of a sock, will cause so much pain it will bring tears to my eyes. Sometimes just the air from a breeze is too much to handle. Although I promised not to talk about epidemiology, I could mention that fractures and sprains are the most common precipitants. Fallon used to be a competitive figure skater, and she has some damage to her foot that eventually required surgery, and that probably was the reason for her condition. CRPS is more common in middle adulthood and among women, with a remarkable 4-to-1 sex ratio. If you're going to go to CRPS meeting, you'll see that most participants are females. Most adults eventually recover, leaving CRPS rare in the elderly. That may be true, but I didn't see any one of my patients that completely recovered from this condition. There is a correlation of CRPS with asthma and with focal or generalized neuropathies, but not with psychological illnesses. In other words, if you're nuts, if you have depression or anxiety, not necessarily you will develop CRPS. There are multiple manifestations of this disease. I'm just going to talk about those that are critical to Fallon. Most of the time, gastroparesis takes a form of dysphagia or constipation. In Fallon, it took extreme form. She's unable to eat, process, and she's unable to empty her bowels. She has to see gastroenterologist every week for bowel disinfection under anesthesia. She is currently evaluated by a surgeon for possible bowel resection or even replacement. Her current weight is 67 pounds. Pathological fractures are very common. Fallon tripped over her dog and had fractured her pelvis and hip in 3 places. She underwent left hip open reduction and fixation. Severe neuropathic chronic pain is associated with poor performance on the neuropsychological tests that assess working memory, language, and executive function. Fallon is exceptionally bright. She was one of the best students in her class. Despite all her conditions, she is looking for applying to PA school. So question comes, why does it spread? What makes it so severe? Why does it involve the entire nervous system? Simply nobody knows. And two most common theories is small fibers. As you know, small fibers are finely myelinated A delta and unmyelinated C fibers. They provide pain sensation not only from somatic but also from autonomic nervous system. And a lot of patients of this condition develop autonomic dysfunction. And the other theory is neurogenic edema, caused by damaged small fibers that activates immunocytes and that starts inflammation cascade. And sure enough, it's a systemic involvement and it's the whole body disease. This slide and some others I borrowed from Dr. Chopra. He gave me his nice permission to do this. This is the model of nervous system, brain, spinal cord, nerves. So most of us, when they have an injury, small or big, eventually will recover. Our body has remarkable abilities to heal itself, but not in case of CRPS. In case of CRPS, pain will spread first to the spinal cord, then to the brain, then to other nerves. Then we have CRPS in progress. Neuroinflammation and autoimmune disorder, I call it environmental theory. As you know, nerves surrounded by glia. And under normal conditions, glia behaves like a lovely wife. It nourishes and protects the nerve. However, sometimes it can be irritated for certain reasons. And the irritated glia will start sending messages to the nerve. And then we have a war in progress. So this bizarre and rare condition has its rhythm of development, progression, and manifestations. And I was thinking how can I interpret it in music. And I came up with the idea of RSD dance. My daughter's a piano teacher playing piano part. Okay. There are multiple treatments available to treat this condition. None of them works. I mean, none of them works 100%. So I was thinking how I can present those treatments to you. And I came up with classification. I put all treatments in 3 categories. Maybe, 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 maybe not, and sorry but no. We'll start with the first one. Ketamine infusions, lidocaine infusions. This is the reason why Fallon came to me in 2011 and she still stays with me. I provide those infusions. David did very nice presentation about lidocaine infusion last year, and I'm not going to talk about them. I will discuss ketamine infusions later. Those numbers in the brackets, they represent references, and they provide at the end of my presentation, so if you're interested to know more, you can Google them online and read the full articles. Physical therapy is extremely important. Aggressive physical therapy helps to restore and maintain function. Fallon was doing physical therapy 3 to 5 times a week, and maybe this is why she's still active. She's still able to drive a car, take care of herself and her dog. Psychological treatment, cognitive behavioral therapy, biofeedback, relaxation techniques, graded motor imagery. They don't cure CRPS, but they help patients to cope, manage, and accept this condition, both emotionally and physically. And they also teach patients how to be active. You have pain, so what? Do something about it. This is the app for motor-graded imagery. You can download it for $6 on your Android or iPhone. Mindfulness, meditation, deep breathing, yoga. If I was able to teach my patient those techniques, I will lose all of them. However, it's not so easy to learn them, so they still are all my patients. Biphosphonates. Pathological fracture is a common problem, so why don't to prevent it? Antioxidants. Alpha-lipoic acid, vitamin C, DMSO, N-acetylcysteine, turmeric, ginger, fish oil. They all found to have some help with the inflammation and with this neuropathic pain. They also have very good safety profile, so why not? Service dogs. You will ask me, what service dog has to do with this condition? This is Scoopy. Scoopy is a felon's service dog. He follow felon on her visits, appointments. As you know, a lot of, actually all of these patients, they depressed and lonely. So it just simply helps to restore quality of life. Marijuana. Marijuana was recently introduced by New York State for medical use. I was one of the first providers who prescribed it, and felon was one of my first patients. So it did help you a lot. I was able to discontinue some opioids because of marijuana. So how does it work? It increases reward, reduce pain, anxiety, body temperature, blood pressure, stimulate food consumption, inhibit motor behavior and induce sedation, mediate extinction of aversive memories and fear, perform neuroprotective and anti-inflammatory functions. In other words, you have problems, you smoke a joint, and you're fine. Maybe not. Also, the spinal cord stimulator. There is a lot of evidence it works. However, the situation with spinal cord stimulator and reflex sympathetic dystrophy, or CRPS, is not so clear. I will compare it with the previous US election, when high expectations didn't meet reality. Yes, it helps pain, but it doesn't help function. In 2-3 years, there's no difference compared to people who has the spinal cord stimulator inserted and people just treated with physical therapy and medications. It does have serious complications, and it's expensive. Felon had it done, but in 3 months it has to be removed because it didn't help her. However, with new technologies and at early stages of disease, it's probably a good choice. Dorsal root ganglion stimulation. I first heard about this treatment on the World Congress of Pain in 2012 in Granada, Spain. Dr. Leon Lam, Tuan mentioned him in his presentation, was showing the audience a few of his cases of RSD treated successfully with DRG stimulation. It sounded too good to be true. A few years passed and there is no much evidence, no many studies that it works available. Besides accurate study from St. Jude, it shows a significant benefit of DRG stimulation over spinal cord stimulator for this condition. I think that DRG stimulation can be a treatment of choice if you have single extremity CRPS. I'm not sure it's going to help patients like Felon who has a widespread CRPS. Deep brain stimulation, another promising study. It sounds attractive to stick a wire somewhere in the brain connected to amplifier and buzz the pain out. However, there is no much evidence that it works. It may be the treatment of the future. Immunotherapy, plasma exchange therapy, low-dose naltrexone. I put all those treatments together because they all treat environment. Remember this slide about lovely wife. I'll start with the British study. English doctor was treating patients with low immunity and pre-existing CRPS with intravenous immunoglobulin. And he found that not only immunity improved, but also CRPS got much better. So they did a study where 3 out of 12 patients reported 50% or more improvement compared to controls. However, we need more information. It's not enough to make any conclusion. Americans did a study on plasma exchange. If CRPS caused by inflammation, some they call it inflammation juices, some they call it inflammation soup, it makes sense to dilute it. And this is what exactly they were doing. They were extracting plasma and exchanging it with albumin in normal saline. And they were providing 5 to 12 treatments. And they found it worked, it helped in the majority of cases. However, it lasted only for 12 weeks, and after 12 weeks, there was no difference compared to controls. To maintain the positive effect, you have to continue to provide plasma exchange every week. Chopra, he wrote an article where he described 2 patients treated successfully with a low-dose naltrexone. His explanation is that low-dose naltrexone antagonized the toll-like receptor 4 pathway and attenuate activated microglia. I don't know what does it mean. Probably Roman will explain me later. But I like Chopra's idea for 2 reasons. First, I can discontinue my patients on opioids and offer them low-dose naltrexone. And second, it may work. So I offered all my patients with CRPS low-dose naltrexone treatment. Guess how many agreed to have it? Amputation. How many of you believe that amputation is a good choice for CRPS?
Can be. Depends, obviously.
You're right. So this is the Dutch study. Among 21 patients, 20 reported an improvement in their lives. 19 reported a reduction in pain. 17 reported an improvement in mobility. 18 out of 21 stated that they would choose the same treatment under the same circumstances. Magnesium. There was a small study from Netherlands that shows it works, but it's not enough evidence so far. Cialis. There was a study that shows it beneficial for patients with cold CRPS. As you know, CRPS has warm and cold stages. Viagra and Cialis nowadays can be used for any incurable diseases. Sorry, but no. Sympathetic blocks. Sympathetic blocks help temporarily, but in long run there is no difference. Having said this, it doesn't mean that I don't do them. Opioids. They do benefit at the beginning, but in long run it's more harm than good. So opioids, you are fired. Neuropathic pain medication, Lyrica, Neurontin, Cymbalta, Savella. They do help neuropathic conditions, but for some reason they don't work for CRPS. Intraradical PARPs, used for many conditions, but there's no evidence it helps CRPS. Hyperbaric oxygen. There was a study that shows that it helps. And Fallon had it done. She actually told me that she likes this treatment, it did help her. However, it's very expensive, and nowadays it's not approved for CRPS. Neuroablation techniques, surgical sympathectomy, radiofrequency ablation. In the US, we don't believe in pulse tariff. We like to burn everything. Fallon had a surgical sympathectomy done. And she stated that it did help at the beginning, but a few weeks later the pain came back with vengeance. Surgery, bilateral anterior cingulotomy. It's common logical to cut the pain pathways and thus stop the pain propagation in the brain. A very small study shows beneficial, but it's not enough evidence. I'll talk a little about ketamine infusion. Ketamine is why does it work? Ketamine, we all know that ketamine is antagonist at NMDA receptors. And NMDA receptors play a central role in the processes of induction and maintenance of pain sensitization. And interestingly, as Mark told in his presentation, it helps depression with acute administration, usually through the nasal spray or sublingual. So I will talk about a few studies. American by Schwarzman, Dutch by Sigtermans, and German by Kofler. So there are a lot of similarities between American and Dutch study. They both use a low dose ketamine, 0.5 milligram per kilo. The difference is that in American study they infuse ketamine for 4 hours over 10 consecutive days. In Dutch, the patient was admitted and ketamine was infused for 100 hours. In both studies, there were a significant reduction in pain scores immediately after treatment that lasted for 12 weeks. 12 weeks or 3 months is a critical number both for pregnancies and for clinical trials. There was no improvement in function despite pain reduction. I don't know the significance of improvement in pain without improvement in function.
It's the first thing you say.
As Atma told the other day, if you have less pain, you want your life back. You want to enjoy activities that you used to do before. You want to have sex with them. And those studies were never repeated. Ketamine coma. It was discovered accidentally in Germany. What happened is that the patient had a brain injury after a car accident, and he was treated with a ketamine coma. In the US, we use benzodiazepines for the same reason. Yes, patient has a pre-existing CRPS. So when the patient recovered after the coma, not only his brain function improved, but his CRPS was gone. Bingo, we have a cure. So to have a ketamine coma, patient has to be admitted, he has to be in ICU, intubated, on ventilator, and it's very expensive treatment. So among 38 patients that he sent to Germany, 12 reported minimal no pain for more than 5 years. It's a great number to me. I will conclude with Chopra's rule of 10. So nothing gives you 100% improvement. But let's say a patient will do physical therapy and he has a 10% improvement. He will do cognitive behavioral therapy on top of it, another 10%. He will start lidocaine or ketamine or magnesium infusion. He starts smoking marijuana, or maybe Cialis, I don't know. But overall, he has a 50% improvement and patient is functional. Those are the references that you can read. This is how fellow envisioned her fight with this condition. And special thanks to Spiros Polakis, my assistant and computer genius who illustrated and designed this presentation. Ready for discussion.
One thing I want to comment in relation to your very nice talk is a terrifying clinical fact. The horrible dysmorphophobia people with complex regional pain syndrome have. They actually hate the limb. They cannot look at it. They're absolutely terrified and they want it somewhere, it's been taken away. It is really very interesting phenomena, and I even can share my personal experiences after severe trauma to my foot with lots and lots of pins and plates there. Yes, I absolutely hated the limb. To such a terrifying extent that I've decided that I will never get rid of my complex regional pain syndrome, which lasted for 3 years. So I will have to name my foot John, or I may name him somebody else, so that I'm looking at John and I like the John and I train myself and retrain myself, and the positive imagery is absolutely vital. So obviously there is usually a progression of improvement as long as you can survive the acute phase or something. But the dysmorphophobia is very little actually written about, and it's an important aspect as far as explaining to the patient what's happening.
I agree with it. That's why they have come to behavioral therapy, more the imagery and our treatments. Yeah, that's